Our next speaker is Dr. Kimberly Foley. Kimberly is she's a critical care medicine specialist and pulmonary disease specialist in Brooklyn. She also lives part of the time in Bermuda, and she's also a CCM patient. She's on our board of directors right now, and has just joined in the last year, and so she's going to be speaking to us about obstructive sleep apnea. You remember Dr. Zafar happened to mention that as one of the risk factors for increasing lesion burden, and so as a pulmonologist, she has the ability to tell us what to do.
Hi, good afternoon, everyone. So today I'm just going to talk to you about obstructive sleep apnea. This is my love, pulmonary disease, and it just so happens that I'm, too, a CCM patient. I was diagnosed last year, actually, today. So I'm happy to be here to share my point of view with you from a pulmonologist, and as well to understand with you the disease that we're going through and the new things that are on the way to help cure the disease. So let's go a little bit of instruction. So we all know what sleep is, right? We go to sleep, we do it every night. And what happens when we go to sleep? Air moves in and out through our nose, through our throat. And it's supposed to happen in a regular rhythm. But what happens with people with sleep apnea? Sometimes they stop breathing, or sometimes it pauses for a little bit. So I'm just going to break it down really simple. Some people have obstructive sleep apnea where they have upper airway disease, and then some people have it's what's called central apnea, where their brain stops telling them to breathe, so nothing moves. Whereas with obstructive sleep apnea, everything's still moving, but the air is not flowing down. So what's sleep apnea? It's a serious condition, so don't take it lightly. It can affect your quality of sleep, your ability to perform your normal activities of daily living, and it can affect your long-term health. So approximately 25% of adults are at risk for sleep apnea to some degree. Men are more affected than women, and as you get older, you're more affected if you are obese or overweight, and then if you have a small upper airway, that puts you more at risk as well. So how does this occur? And this is a picture basically showing how the top figure is how we normally breathe. You have the soft palate that's there at the back of the pharynx and the larynx. Then you have your epiglottis, which is what you see right here on the tongue. And then your ear flows through down into your trachea and into your lungs. So what happens with sleep apnea, your tongue falls back. Right here, your uvula, that little thing that sticks down in the back, and then there's no flow. So you're not really getting any air to your lungs and any of your other organs. Okay, so some people are affected by this, and some people are not. Okay, some people can snore when the tongue falls back. Usually, it's not really a problem to the patient. It's a problem to the bed partner, okay? And that's how the patient used to present to the office. Dr. Foley, oh, my husband snoring like heck, he's keeping me up all night, and the patient's like, no, honey, okay? So this is what usually happens. But they also complain of other things, which we're gonna go through: the tiredness, the sleepiness, the lethargy. So you can have a full obstruction where your tongue falls completely back, okay? And if that lasts for more than 10 seconds, in a period, 1 minute, then that's called an apneic episode. If it's less than 10 seconds, it's called a hypopneic episode. Okay, so when you go for a sleep study or have that performed, they're calculating that number as to the severity of the disease, which I'll talk to you a little bit more about. So what's the physiology of it all? It's an insufficient breathing pattern due to apnea or hypopnea, which I just mentioned. It causes your oxygen levels to fall and your carbon dioxide levels to rise. So what does that do? It can cause problems to the brain, okay? And this is why we're here, to actually discuss this. Because the airway is blocked, you start to breathe a little faster, so their bed partner says they're breathing and they're gasping in their sleep, but they're not really waking up. So no matter how fast you're breathing or attempting to breathe, your oxygen levels are not going to get better until that airway is actually reopened. So that's when they actually wake up, they sit up, or cough or snort or whatever they do, okay? Once the airway's open, they take a few deep breaths and then they fall back to sleep. Sometimes, like I said, they snort or they make a loud noise or grunt, and then they go back to sleep without any full recollection of what's going on. But this awakening throughout the night, multiple times per night, can give an unrefreshing sleep, and that's what causes the daytime sleepiness and the fatigue throughout the day. So there's other anatomic causes of obstructive sleep apnea. They have a small upper airway, we call micrognathia, where they have a really small jaw, or they open up their mouth and it's little itty bitty, or they have a humongous big tongue. As you gain weight, you get a big fat neck. All of this fat tissue can also cause you to have obstructive sleep apnea. While these factors are increased in sleep apnea, they're usually not noticeable, and the patients aren't able to really detect. It's usually the bed partner that's able to tell what's really going on. So what are the sleep apnea symptoms? Snoring, the fatigue, and the daytime sleepiness. These are the main things that the patients complain of. Some people, like I said earlier, they have no symptoms. I'm tired at work. I can't do the things that I normally used to do. Some people actually have bedwetting, restless sleep, sexual difficulties, headache in the morning, and this is complicated with our disease because some of us have headaches anyway, okay? Waking up in the middle of the night with a sore, dry throat, sneezing, choking in sleep. So these are the kinds of things, if you have these symptoms or your partner has these symptoms, to keep it in the back of the mind. Maybe they have obstructive sleep apnea. So, like I said previously, the risk factors, increasing age. As you get older, you're more at risk. Being of a male sex, it puts you at 2 times more risk, especially as you age. Obesity, and then if you drink alcohol or use some medications. Now, some of us are on medications, antidepressants, sedatives for sleeping. These can actually relax those muscles of the tongue and cause the tongue to fall back, which actually makes the obstruction worse. And then, like I said previously, you can have an anatomical airway problem. So what are the complications for sleep apnea? The daytime sleepiness, the difficulty in concentrating, you're not able to do things at work. Somebody's finding you at the desk a little slumped over and they give you a nudge. Sometimes that happens, sometimes it doesn't. What about driving in the car? Falling asleep, nodding off. So studies have shown that people with severe obstructive sleep apnea are twice as likely to be involved in motor vehicle accidents. Okay, so that's something, if obstructive sleep apnea is something that we're thinking about, it's best to get tested because not only are you putting yourself at risk, you're putting your community at risk, okay? So this is something that you should talk to your provider about, especially if it's affecting your driving or your working abilities. The other things that you have to be concerned about with obstructive sleep apnea, not only does it affect those things, it affects cardiovascular issues, like it can give you atrial fibrillation. Because what happens when you have that decreased airflow, you're not getting oxygen, not just to your brain, you're not getting it to any of your other organs, okay? So it puts you at risk for heart attack, pulmonary hypertension, stroke, and the atrial fibrillation. I just saw a patient last week in Bermuda, but I had diagnosed his atrial fibrillation because we actually had sent him home with a pulse oximetry overnight, and he was on CPAP already, had been previously been diagnosed by an ENT specialist, but his pressures weren't high enough to overcome his tongue falling back. So he still wasn't getting the oxygen that he needed, and his heart rates were in the 180s. But it only happened at night, and he only complains of tiredness and sleepiness. But we were only able to pick that up because we did that pulse oximetry. So now not only is he on he's not only on the CPAP machine, he's on oxygen to compensate, and the atrial fibrillation has gone away. So it's now what we call paroxysmal atrial fibrillation, but he has to be on anticoagulation for that. So These are the things that we have to keep in the back of our minds. So how do we diagnose it? Usually you want to go to a pulmonologist or a sleep specialist, and then they're going to take a big picture of everything that's going on with you. They'll do a physical examination, or at least they should, okay? And they're going to ask you about your sleeping. Is it effective or is it ineffective? They're going to measure your neck. If you're a man, it should be, if it's greater than 17 inches, or a woman, if it's 16 inches, it puts you more at risk, okay? Then they're going to assess your upper airway. They're going to look in the back of your throat to see if you have a large tongue. If you have high blood pressure that's uncontrolled, it could be the actual apnea causing the vasoconstriction of your vessels, which is not allowing you to be controlled with your blood pressure medications. And then they're going to ask your partner. Sometimes they ask the partners to come to the office to just see what symptoms the patient is actually complaining about. Are they having those choking or gasping episodes? So the sleep study, I'm not sure, maybe you have a friend, maybe you've had this study before, but they kind of hook you up like a whole neuro unit. They put probes on your head, one around your chest, one around your belly, and they put a pulse oximeter on, okay? And that's called a polysomnogram, okay? And it measures your breathing, your effort, your flow, your heart rate, your rhythm during various stages of your sleep to see exactly what's going on. And they also check for periodic leg movements because that could also cause disruptive sleep. And then there's also home monitoring. If you're a pretty high risk, like we went through some of the signs and symptoms, if you're pretty high risk and we think we could diagnose it, we can also send you for a home study. And that's easier to be picked up, and people like to be in their home environment. So that checks for the oxygen saturation, the position of the patient, and the heart rate as well. So I talked about the severity of the disease. So most of us that are normal sleepers, we actually do have apnea, hypopnea episodes. But if it's less than 5, okay, per hour, we're normal, okay? And your oxygen levels are usually going to stay above 90%, or they should be. Now, if you're mild, you're going to have between 5 and 15 episodes per hour, and your oxygen levels can drop between 90 to 86%, okay? The cutoff, we would say, is 90%, okay? Now, these people may or may not have symptoms, but they may have a little tiredness, be sleeping while reading, dozing off after lunch like some of us are doing, okay? Moderate, 15 to 30 episodes, and their oxygen levels are going high because they never get a chance to recover. And they may be sleeping during a meeting. Or severe, greater than 30 episodes, and their oxygen levels go to less than 80%. And they can be sleeping while driving or even fall asleep while eating. So it's pretty bad. So what's the treatment? Again, you're going to be seeing your pulmonologist or your sleep specialist. And the goal of the treatment is just to keep that airway open, okay? And it's to eliminate sleep disturbance. So you don't want to be waking up during the night. You want to have a full restful sleep so that the long-term consequences are eliminated, the heart failure, the pulmonary hypertension, the atrial fibrillation, okay? So what is required is a nightly use of some sort of device, okay? And that's CPAP, and we're gonna go into the next slide and I'll talk to you about that. The main problem is that because you have to use it every night, like taking a medicine or anything, compliance can be an issue, okay? So we have to come to some agreement of what the patient is willing or not willing to do. So here's the CPAP machine, and this is the most effective and common first treatment for sleep apnea. So basically what it is, it's positive pressure that's being blown into your airway to keep your tongue off the back of your throat. Okay, and that's how the air gets into your lungs and able to keep you oxygenated. Okay, it's put on a tight seal around your nose or mouth, okay? Some people actually have the big facial devices, but those are less comfortable, okay? And that's how the air is able to go back and forth, okay? So if you're falling asleep during the day and your patients are at home, like my patients are at home sometimes, then I say to use at night and while napping. Now, if you're at work, then you're obviously not going to be able to use your CPAP device. Now, there's other things that people use. It's called adjust sleep position. Adjusting the sleep position to actually stay off the back. Some people don't want to use a CPAP machine. So, doctor, do you have any other options? Well, they've done some studies to say, okay, we'll put tennis balls on the back. And maybe if you roll on your back, it's going to be uncomfortable and you'll move back into the right position. This is not a good option, but it has been done before, okay? Something that we can all probably benefit from, some weight loss, okay? It's very useful, especially if you've developed a CPAP from being obese, in a recent increase in weight gain, okay? Obstructive sleep apnea from a recent increase in weight gain. So there's things that we can do. We can change our diet, maybe to the plant-based diet. We can do some more exercise. But what we have to keep in mind, weight is difficult to maintain, and only about 5% of the whole population that tries to lose weight is able to keep it off for an extended period of time. So that takes us back to the use of a CPAP machine. Like I said earlier, we should avoid alcohol and other sedatives, okay? Because what does alcohol do? It makes us feel relaxed, but it also relaxes those muscles in the back of the throat, okay? Which also puts us at risk for increased accidents and injury. I counsel my patients, if they have sleep apnea, just don't drink at all. Try to avoid all sedatives because we don't want to make the obstruction worse. Now, if you have been diagnosed with sleep apnea, then you have to worry about surgeries as well, because if you go for a daytime surgery, they may just give you midazolam or something to do a colonoscopy, and that too can increase the risk of you having an obstructive episode during a colonoscopy or any daytime procedure, because those muscles are relaxed. So that's something that you have to keep in mind as well. There are dental devices. Basically, you put something like a mouth guard in that can actually bring the jaw forward. These things tend to work, but it's usually for patients that have mild apnea. Now, if you're stopped breathing for 30 times an hour, you probably most likely need the CPAP machine. Did I skip a slide? Okay. Surgery, last resort. This is also an alternative. This is for people that have severe obstructive sleep apnea. They are not tolerating the CPAP machine, and they say, okay, doctor, or they send them to the ENT physician to actually do a procedure to help open up the airways. And basically what we talked about was the uvula, the little guy back there, okay? They kind of cut it and remove it all away. If you have tonsils that are really big, they just remove all of that. And that's called a uvulopalatopharyngoplasty. Easy, UPPP. Okay? So basically removes the uvula, the excessive tissue in the throat, and tonsils, if it's present, just to completely open up the airway. There's another thing that they do for surgery. It's called maxillomandibular investment, MMA. And they kind of push the jaw forward, okay? And this can address the upper and the lower pharyngeal airway as well. So they're able to just push everything forward so that the airway is actually opened up in the back here. Now, for my morbidly obese patients, 300, 400-pound patients, not only are they hypoxemic, which means they have low oxygen levels, they have hypercapnia, which is like high carbon dioxide levels, okay? So they're failing their CPAP, no matter what you do, they're not using it. And they come in hypoxic respiratory failure, hypercapnic respiratory failure, that they can't exercise, okay? So the only last resort may be a tracheostomy. And basically that's a permanent insertion of a hole into the neck. This is drastic, but sometimes it's only the life-saving treatment for these patients. And then after they have this, they don't have any obstruction anymore. You no longer have obstructive sleep apnea because you're now breathing through your trach, and all of the upper airway obstruction has been eliminated. And new on the market is the Inspire transplantation. So basically this is like a little pacemaker that they insert in the chest, and it hooks up to the hypoglossal nerve, which is affecting the hypoglossal muscle. and it kind of triggers when you have an episode of apnea and lifts it up, okay? This is reserved, again, for your extreme cases of severe sleep apnea or moderate sleep apnea, and they're refractory to these other options. So, how many of you have sleep apnea? You don't have to answer, but let's go through the stop bang questionnaire. And this is the things that I give to my patients. So, I'm not sure if you can all see, but keep this in the back of your mind, because maybe after today you might want to speak to your physician about whether you have sleep apnea. Do you snore? Yes or no? You don't have to answer me, but do you feel tired? And do you often feel tired, fatigued, and sleepy during the day? Have you observed sleep apnea? Your wife or husband, they nod you and say you've stopped breathing, or you wake up gasping for breath, okay? Do you have high blood pressure? It's difficult to control. Do you have a high BMI? Okay. Are you older than 50? You don't have to tell. Do you have a thick neck? I think it said 17 for men and 16 for women. So you can take a tape measure. And are you a man? I can see who's a man and who's not a man. So now, if you have a score of 0 to 2, you're low risk. If it's 3 or 4, it's intermediate risk. And if you answered 5 or more, you're high risk. So you're the person, if you're 5, you should be speaking to a sleep specialist about possible sleep study for obstructive sleep apnea. And that's all I have for you today.